So hello guys, welcome to final year. In today's video, we will be talking about some small topics but very important topics. These are fracture disease, splinting, complications of fracture, compartment syndrome and myositis ossificans. तो फर्स्ट हमारे पास है फ्रैक्चर डिजीज। तो फ्रैक्चर डिजीज को हम कैसे डिफाइन करेंगे कि जब हम किसी फ्रैक्चर का ट्रीटमेंट कर रहे होते हैं तो हम लिम्स को इमोबिलाइज करते हैं and due to that immobilization some disadvantage are there of the immobilization. These are stiffness of joints, muscle wasting and all, and these things are considered as fracture disease because these are the disadvantage of immobilization of the limb. Okay, and to avoid them we have some principles that we follow, that is interfragmentary comparison, then splinting and then combination of the both. Okay, so this is all about fracture disease. Next we have splinting. In splinting, first no rigid fixation is there. Then we have three types of splinting, that is intramedullary splinting, extramedullary splinting and outside of the body. Okay, intramedullary splinting we do for long bones. Extramedullary splinting, that can be done for any fracture. Okay, and plates are used in it. Okay, then outside the body we use for the open fractures. Okay, these are the three types of the splinting. Okay, and then we talk about complications of. In immediate complications we have systemic and local complications. In systemic complications we have hypovolemic shock, and in local complications we have injury to major vessels, injury to muscles and tendons, then injury to joints, then injury to viscera. Okay, so like that we have early complications. These are also divided into systemic and local complications. In systemic, again we have hypovolemic shock, then ARDS, then fat embolism syndrome, then others are there which are not important for us. Then in local complications, infection and compartment syndrome. Those I have highlighted. These are of importance of our perspective. Okay. Then we have late complications. In late complications, imperfect union of fracture is one thing which is responsible for late complication. Then other factors are there. Imperfect union of fractures. Uh, this is divided also again divided into delayed union, non-union, and mal-union, and cross-union. Okay, we will talk about them in a minute. But other than that, we have avascular necrosis, shortening, joint stiffness, then ischemia contracture, then myositis ossificans, and osteoarthritis. These are the complications of the fractures. Okay, immediate, early, and late complications. So those I have highlighted. They are of the importance of us, and we will talk about them in a minute. So first we have delayed union. Delayed union, what does that means is when fracture takes more than usual time. मान लीजिए एक फ्रैक्चर टाइम लेता है एक महीने का हील होने में, किसी बोन का फ्रैक्चर हो गया तो अब वो ले रहा है 2 महीने हो गए, 3 महीने हो गए, बट इट इज नॉट यूनाइटिंग, देन वी विल से इट डिलेड यूनियन. ओके, second we have non-union. Non-union means when fracture healing fails to unite and do not progress. Okay. अच्छा, अब हम इन दोनों में डिफरेंशिएट कैसे करेंगे, डिलेड यूनियन और नॉन यूनियन में. नॉन यूनियन, फॉर योर नॉन यूनियन we give the deadline for the 6 months. Okay, and below 6 months if healing occurs and it is taking usual more than usual time, then we will say that it's delayed. Okay, but when we will call it non-union, it is after 6 months. Okay, and how we will diagnose it? By the serial X-ray evaluations. Okay, and we will be having clinically presence of mobility. Where the fracture occurred, there we will be having the presence of mobility. Then presence of pain at the fracture site, means if we are touching that site, it is painful. Okay, so these all things will be there in the non-union. In delayed union, just that it is taking more than usual time, but it is it is getting united. Okay. So now then we have some causes for the non-union. These are can be related to patient, related to fracture, or related to treatment that we can read from the book. But after that we have types of non-union. Okay. In types we have atrophic and hypertrophic. In atrophic, where there is a minimal or no attempt at callus formation, means there is no callus formation is occurring. Okay, then we will call it atrophic. And hypertrophic, where though the callus is present, it is not bridge. It does not bridge the fracture site. Means it is not able to bridge the fracture site. That is called hypertrophic. Okay, then some common sites are there for non-union. These are neck of femur, scaphoid, then lower third of tibia, lower third of ulna, and lateral condyle of the humerus. Okay, these are some common sites for non-union where the if where fracture is occurring, it is likely to be going into non-union. Okay, so next we have consequences. What will be the consequences of non-union? And delayed and non-union both. Delayed and non-union can result in persistent pain, deformity, or abnormal mobility at the fracture site. A fracture in delayed union, if stressed, can lead to refracture. Means if we are pressing, if a fracture is in delayed union, and if we are pressing it or giving some stress, it will be refracted. Okay. Then some diagnostic points are there. How we will diagnose them? Yeah. So we have some points. These are persistent pain, then pain on stressing the fracture, then mobility is present, then increasing deformity at the fracture site. These will be the some diagnostic points, and then we have some radiological factors that will help us in defining whether it is delayed union or non-union. So in delayed union, we have fracture line visible, okay, and inadequate callus bridging the fracture site. That is important point. In non-union, also we will be having fracture line visible. A little bridging callus can be present, and fracture ends may be rounded, smooth, or sclerotic. Okay, and the medullary cavity may be obliterated. These points will be there for the non-union in radiological feature, and the fracture line visible and inadequate callus bridging in the at the site fracture site, these will be the delayed union factors for the delayed union in the radiological features that will be defining features. Treatment: open reduction we can do, then internal fixation we can do, then bone grafting if the fracture is going into delayed union or non-union, then we can go for bone grafting. Then if excessive formation of bone is there, then we can excise the fragments of the bone which is giving some malunion or something. No? Then in some conditions, if just delayed union is there, then there is no treatment required. Okay. Then one method is there, that is Iljarov's method, which is also written in the Maheshwari. Okay. Then next we will talk about malunion. What is malunion? Malunion is when a fracture does not unite in a proper position. Okay. Malunion directly says no that whether it is going to unite but not in the proper position. Okay, the resulting disability is of clinical significance. So yeah, so when we will say the malunion, when the unite the person it is uniting, and it is uniting in proper position, in proper position. Okay, and it is giving clinically significant disability causes. What are the causes of malunion? Improper treatment, then unchecked muscle pull, then excessive comminution. Okay. Then we have common sites. What are the common sites for the malunion? These are the fracture at the end of a bone. Like a fracture is going to be on the end of a bone, then it is very likely to go in malunion. Example: supracondylar fracture of the humerus. Okay, and Colles fracture. Okay. Then consequences. What will be the consequences of the malunion? Deformity. shortening of the limbs, then limitation of the movements. Okay, so these all things are important for the malunion. Next, we have treatment. So when not the treatment will be required. So for malunion, so the conditions where treatment will be required are if a deformity is there, shortening of limbs are there, and functional limitation is there. So then we have to go for the treatment. Then what will be the methods of the treatment? Osteosclerosis, then redoing the fracture surgically, okay, then corrective osteotomy and excision of the that deformity. And when we will not be requiring the treatment, this is the small deformity is there, or which is not giving us some deformity, the malunion which is not giving us some deformity, and the remodeling function of the bones will take care of that. Then we can leave it for the remodeling. And what will be the factors for the remodeling which will affect it? These are age. If patient is a children, it is more likely to get remodeling as soon as possible. But if it is adult, then it is very unlikely to go in the remodeling, or it will take more time. Okay. Then the type of deformity, then angulation in the plane, then location of the fracture. That what is the location of the fracture? Okay. Yeah. So next we'll talk about compartment syndrome. The limbs contains muscles in the compartments enclosed by the bone, fascia, and interosseous membranes. The rise in the pressure within these compartments due to any reason may jeopardize the blood supply to the muscles and nerves within the compartment, resulting in what is known as compartment syndrome. Basically means if a part of a limb is compressed or getting pressurized, then the blood supply of that part will be hampered, and this will cause compartment syndrome. Okay, what are the causes? Any injury leading to the edema of muscles. Okay, then fracture, hematoma within the compartment, then ischemia to the compartment and leading to the muscle edema. These are the causes of the compartment syndrome. Then what we will be the consequences? For that we have five P's. These are pain, pallor, pulseless, then paresthesia and pressure that is increased. Okay, these are the consequences. Then this is the cycle which take place in the compartment syndrome. That is Atten and Green cycle of compartment syndrome. That is I have taken from the Maheshwari. Okay. Then what will be the treatment for the compartment syndrome? That is fasciotomy or fabulectomy. Okay. Fasciotomy, the deep fascia of the compartment is slit longitudinally, and in fibulectomy, the middle third of the fibula is excised in order to decompress all compartments of the leg. That is for the legs compartment syndrome treatment. Okay. Okay. Then next topic we have myositis ossificans, जिसे हम कह सकते हैं post traumatic ossificans, or we can say it muscles का bonification. Okay, then ossification of muscles. Then this is the ossification of the hematoma around the joint, resulting in the formation of a mass of bone, restricting joint movement and often completely. It is what are the causes of the myositic ossificans? This occurs in cases with severe injury to the joint. Then common in children, common around the elbow joint, in patients with paraplegia. And massage following trauma can aggravate that myositic ossificans. What we will usually do that whenever we'll get some trauma, we will massage it, that part. That is very long, that can easily aggravate the myositic ossificans. And what will be the consequences? Stiffness of the joint and loss of movements, obviously. Then we will be doing some treatment for that. That is watchful inactivity. that we will not be mobilizing that point, that portion of the limb and that portion of joint. That is watchful inactivity, rest, and gentle stretching. Then as NSAID is for relieving the pain, and physiotherapy for the mobility of the limbs to regain it. Then surgical excision of the bone mass. If it is getting worse and movements are not feasible, then we will go for surgical excision of that bony mass. Okay. And the very important point is massage is strictly prohibited after trauma, because this is very aggravating factor for the that what will say myositic ossificans.